Good morning, everyone. Thank you for joining us today for our MTAC office hours. And just quick introductions. My name is Danielle Ragib. I'm a training and technical assistance specialist with the Center for Applied Research Solutions, and I'm working on the Medi-Cal Mobile Crisis Services benefit through the TA Center. Pass it on to my team members who do quick introductions.
Good morning, everybody. I'm Miranda March. I also work for the CARS team. I'm the project director on the MTAC, and I'm delighted to see so many people here today.
Hi, good morning, all. Andrew Hahn, I'm the project manager for the CARS MTAC team. Nice to be here with y'all. I'll pass it to our next team.
Thank you, Andrew. And David is not here today, but many of you know David. He is also another training and technical assistance specialist with the CARS team. And then I'm going to pass it on to Suzanne real quick to do a quick introduction.
Yes. Good morning, Suzanne Rabideau. I'm with Health Management Associates, and we have the pleasure of working with CARS for the MTAC support of implementing mobile crisis services. So glad to be with you all today, talking about a very important topic of billing and reimbursement.
Thank you, Suzanne. And like Suzanne said, today we will be covering billing and reimbursement. We will provide a quick status update on the implementation plans. I know you've all been submitted on time. Thank you so much. And we are now going through the resubmissions. And then we are going to go directly into the Medi-Cal Mobile Crisis Services Benefit FAQ that was just recently published. We will go over that in terms of the reimbursement and billing. And then we will have some time for some additional questions for any follow-up that or additional questions you might have after we review the FAQ and go from there. Just quick reminder to access all the required and supplemental trainings. You can go to the Medi-Cal Mobile Crisis Services TA Center website, and you can access all the trainings under the Archive Trainings tab. There is a section for required and supplemental. To obtain any certificate of completion for any training that you complete or watch on the MTAC website, you can email mobilecrisisinfo@carsrp.org, and with the subject line certificate of completion, and we will send you a link to access your certificate. Sometimes it can take up to 5 business days to receive your certificate or for us to process your request, so we appreciate your patience. Just a quick update. The MTAC team is currently reviewing revised implementation plans that were submitted on 12/1/23. If you have not submitted your revisions, please do so or send us an email with any status updates you might have. MTAC team will directly communicate with each county if any additional information is needed in the IP. DHCS will directly provide counties a status of their implementation plan. So whether it's a pass, a conditional pass, or not, and that will come, like I said, directly from DHCS with more details as well within that correspondence. If you would like support or individualized TA, please submit a TA request to the MTAC team, and we will put the link in the chat now. That way you can request TA. And now I'm going to hand it off to Suzanne from HMA, who is going to go over the DHCS Medi-Cal Mobile Crisis Services Benefit FAQ that you've all been waiting for.
Well, good morning, all. Andrew is going to put a link in the chat so that you can see the actual FAQ. What I'm going to do is read. First off, the FAQ that you'll have a link to has many topics, but we're going to focus on the latter part that begins on page 8. That addresses specific to reimbursement, billing and reimbursement for mobile crisis services. I'm going to read the question and then I'm going to summarize and not read to you what the document says. So with that, could someone please Question 23. How did DHCS calculate the hourly rate for a team of 2 mobile crisis service providers? So DHCS used what they generally use to develop outpatient services for LPHA or a licensed mental health professional and one other qualified service provider. So they use those 2 categories to develop the rate. And the hourly rate for one mobile crisis team member to provide follow-up is an average of the 2-person rate. Providers on the same mobile team should not claim separately. So there's one claim that is submitted for the 2 individuals on a team, and there's one note written for the interaction. How will mobile crisis teams be reimbursed for transportation? As I said a little earlier, everything is assumed to be included in the rate, that the required activity, except for transportation. That is billed on top of the encounter rate, and it's the time that the team is spent in the travel. Also, if it's inclusive of the time they travel, as well as time that they may spend, say if they transport them to a crisis stabilization facility and there's time spent there supporting the member until they can be seen, that time is also included in the rate for the transportation. And there's also mention of the codes that are used for that. What administrative costs are included and how do counties receive reimbursement for administrative cost? The FAQ provides a link to the plan letter 05-10, which informs how to be reimbursed for the administrative cost. How should a county claim for mobile crisis activities that occur outside the initial mobile crisis response? So all activities that the mobile crisis team does is included in the rate and the encounter, including the follow-up. And the follow-up may happen on the 2nd day, the 3rd day, but that activity is included in the rate. As we said earlier, transportation is outside of that rate. Question 27. If a mobile crisis team that includes a community health worker delivers the services that cannot be claimed under the new benefit, for example, if they respond to a non-eligible location, such as an emergency department, does the community health worker team then need to meet qualifications for SMHS, other qualified provider, for the service to be reimbursable? So in essence, no mobile encounter can be encountered when it's one of the listed items in the bin that says these are not allowable sites. Allowable sites are more community-based, and the detail of that is in the bin. So all community sites except for a few facility-based typed, you cannot bill for that. If someone does go to, say, an emergency department to respond, they could bill under other codes, not using the place of service 15. They could bill. They must meet all the other requirements. So if you have a community health worker that responds and they're going to bill using another code, they have to meet those requirements. How should a county behavioral health delivery system claim for more than one response to the same member in a short period? So say a mobile team goes out early morning, then they go out late evening, or they go the next day. You would encounter another mobile crisis service so long as all of the elements that we talked about in the first question are met. So you go out, you assess the situation, you do the intervention, and all 4 of those components are mentioned, then you can rebill for mobile crisis services. Question 29. What if there are multiple crises within a period of a few days? can there be one follow-up for the mobile crisis response? In essence, yes, there could be one mobile response. However, every issue of crisis that was discussed during the mobile intervention must be addressed. So if you are able to, in one follow-up, address the different issues of a mobile response, you could do that. If not, you would need to do another follow-up to address that particular, to be sure to include all of the issues. Can crisis planning be done as part of the follow-up check-in? In essence, the crisis planning should be done at the most appropriate time that the individual is receptive and open and able to participate in crisis planning. So in some situations, it's during the mobile crisis intervention, and in other times, it's going to be during a follow-up. Question 31, will mobile crisis teams be reimbursed for no-shows? In essence, if there's not a service delivered covering the 4 components discussed earlier, it is not an encounterable service. What happens if counties operationalize their mobile crisis teams differently than what the rate methodology accounts for? Can a county have a unique and distinct rate methodology? In essence, the state is going to use a consistent methodology for all counties. However, counties can talk with DHCS and share information to explore and account for differences, but it's still going to be applied in the same exact methodology. As there's lessons learned throughout doing mobile crisis services, you may need to go back to DHCS and have a conversation to continue to refine what the mobile crisis rate is over time. So there's a consideration that certainly lessons will be learned and there'll be more conversation, but there will not be distinct methodology per county. Are counties able to claim for mobile crisis services through either the SMHS or the DMC ODS delivery systems? Counties can claim through any of these delivery systems. However, there's only one claim that is submitted per an encounter. How does the encounter rate calculate standby time per team per day? The rate development does account for standby time. The federal requirements require that there's a 24/7, 365 day, that there's available teams. So there is standby time calculated. DHCS explains in this FAQ what they did to develop the standby time. In essence, a county's rate reflects a standby time of 1 hour per an 8-hour shift or a longer time period based on the expected demand, whichever is higher. How does the encounter rate incorporate the time that mobile crisis team members must spend getting to the site of where the mobile crisis, where they need to go to meet the person? DHCS's rate does include travel time to and from where they need to meet. DHCS utilized the Crisis Resource Need Calculator that is published by NASHBID, the National Association of State Mental Health Program Directors. They use the time in there to calculate the time needed to go to and from meeting a person in the community. So they doubled the time that was listed in the calculator to get there. How does a mobile crisis team claim for a consultation with the specialist via a telephone and telehealth? So if consultation is used, there is one mobile encounter, but the clinician providing the special consultation will also bill for the telehealth services provided using the appropriate modifier. How will counties claim if additional follow-up occurs after the 72-hour follow-up timeframe? For example, there are 3 additional follow-ups over the course of the next 2 months to engage the individual. In essence, the follow-up that's occurred within the 72 hours would be part of the encounter, and then other services that are provided outside of that, say outreach to support the person to get to services because they need that, those could be claimed separately and according to other claiming requirements. So that is the extent of the FAQs. I think what we'll do now is stop and see if there's any questions in the chat, or if anybody would like to raise their hand and ask a question.
We had a question come through in the chat, Suzanne. I'll read it for you. If additional, and this is coming from Jill, if additional follow-up services such as case management linkage are billed outside of the required follow-up within 72 hours, can those be billed separately?
I was going to say, I actually probably need to read, some of these things get so specific and you need to like really read a question to be precise. But let me talk about it in essence. So a mobile team doing the care and doing those activities and doing follow-up, that would be included in the encounter. If they are connecting with a case manager or another service provider of some type, that person would be billing for their activity in it, just like they would be doing and coordinating any other care provided. And if DHCS wants to add to anything that I just said, please do. Is there another question, Danielle?
There's a question in the Q&A. Are core and other trainings covered through existing administrative costs?
So administrative costs are covered through the guidance provided by DHCS. In that FAQ, there is a link to a document that will explain how to do that administrative billing outside of the cost of providing the actual mobile crisis encounter.
That was all the questions we've received so far in the chat or in the Q&A feature. We will open it up if you feel free to unmute yourself or again, place the question in the chat or in the Q&A feature and we will get to it as quickly as possible. I see one coming in from Christina. Does it matter how the call comes in order to bill the mobile crisis rate? 911, 988, or the local number?
I'll take a stab at this, and DHCS if you want to correct me, but to bill for a mobile encounter, you have to provide the activity that it's stated in the bin. And if you're doing that, you are providing mobile crisis services under this benefit. And so regardless of how that was initiated, if you're delivering service, you are able to encounter. And in fact, we do encourage, it's encouraged that third parties would be calling in and you'd be getting referrals and transfers, and we want to be proactive. And so, yes, it is a covered, as long as you are meeting the requirement of what a mobile crisis service is.
Yeah, and as long as you're providing the service in a setting that is approved, so
Correct.
in those non-restricted settings. That's an important piece as well. There's another question from Shirley. If the case management provided is within 72 hours, is this considered part of the follow-up or a separate case management billing that Suzanne mentioned?
So all of the follow-up that happens within the 72 hours is considered part of the original encounter. And DHCS is very clear in the FAQ that, it could be one call, it could be 10 calls, it could be one unsuccessful call, but everything that happens within that 72 hours is attached to the initial encounter.
Thank you, Miranda. We have a question from Daphne. How will cost associated with the call center be covered? I'm not sure I fully understand that question. Suzanne, are you Do you need any more information there?
I think it's about the activity that's happening when you take a call and then you're dispatching. I think I need to punt this one to DHCS if they're able to answer it today, or if we need to take that as a follow-up and respond to that.
Yeah, hi, this is Chuck Anders with DHCS. I think in our previous, I think we've issued guidance on this in the past, and the call center is considered an administrative cost, so it would be reimbursed through the administrative claiming process that was discussed earlier. So it's similar to how we would reimburse counties for their 24-hour call center that you need to have when you're operating the mental health plan or a DMC ODS county. So it is we're not treating it any different than the 24-hour call center.
Thank you so much, Chuck. Next question is from Kelly. With the hope that we are being proactive, is the dispatch tool necessary for all encounters? And I can answer that, Suzanne, or you can answer that.
So the tool is to support thinking through sending someone. If there's enough information to know this is a need and we need to send someone, you should be sending someone, but you also should be going through the document and filling in that information so that there's a history, there's a record. A mobile team could go, and maybe we saw earlier this example, somebody might be going the next day, right? There might be then there's a record of what happened the day before, and there's information. So the tool is needed to support sending someone and to collect information. But if you know right away you need to send someone, do that. In fact, do that. We need to be proactive and get people the support they need.
Yeah, and also the tool is required. So it's a standardized dispatch tool that is required for all encounters. And so anyone receiving a mobile crisis service should have had the dispatch tool should have been completed for that encounter. Okay, Molly has a question. To follow up on the training question, is training considered an administrative cost, and would it be considered personnel administration in letter 05-10?
I think that's another question for DHCS.
Yeah, typically training of providers, like individuals who are rendering services, is part of, when we were in a cost reimbursement world, it was part of the cost of rendering a service. It wasn't an administrative cost. Training isn't considered a cost of operating the plan. It's the cost of making sure that individuals are appropriately able to render the services that are covered, and it's part of operating a clinic, or the sort of area where services are rendered. And so my initial kind of take is it's not part of administrative costs, it's part of the cost of the service, and it would be reimbursed through the rate. And we did include within the rate build overhead, and so that would be a typical overhead cost for any provider, which is ongoing training for staff.
Thank you, Chuck. The next question is from Raiden. If a client is referred to a psychiatric hospitalization from a mobile crisis encounter and a 72-hour follow-up cannot occur, would we not be able to claim the new mobile crisis benefit rate?
Danielle, I'll jump in here. Follow-up the thinking about follow-up is all inclusive, right? So if a person went to a psychiatric facility or crisis stabilization, following up with that facility, are they going to the right place? What's happening with them? Would be a follow-up activity. And so think more broadly about what you're going to be doing in your follow-up activity. And then you could document that there was follow-up with the facility, the person is scheduled to go home, they are getting connected with the services, or whatever the case may be. So think broadly about what follow-up is.
I just want to jump in as well. This is Corrine from DHCS. That is outlined in the behavioral health information notice as well for mobile crisis services. So it does indicate that for the follow-up check-in, documentation needs to happen in the progress note that the beneficiary could not be contacted despite diligent effort. So to Suzanne's point, you know, you don't necessarily have to speak with the person in order to conduct the follow-up activities, but there should be documentation of what was done and whether the member was reached and those details.
Thank you, Corinne. Going to shift into the Q&A just really quickly. We have a few questions in there as well. We have two from Vanessa. If a call comes in from 911 and no standardized dispatch tool was used, and a team is dispatched who is stationed regionally at the police department, if all other elements of the mobile crisis benefit are met, is this billable? Do you want to take this, Suzanne?
You know, I think DHCS could provide an answer to the more detail of this, or get back on this question.
So I think we would need some additional information. Just reading the question, it's not necessarily clear to me who all is being dispatched, if it's a team. So again, in order to claim for the Medi-Cal Mobile Crisis Services, there needs to be a two-person team, which is outlined in the BIN. Law enforcement is not one of those two people. And so it's not clear to me exactly what's happening from that particular question.
Vanessa, would you like to come off mute and provide some clarity?
So all other elements of the BIN would be met. The clinician is just regionally located there, responding with a dyad not consisting of law enforcement, but just the call came in a different way, so no dispatch tool was used. That's the circumstance.
When you say the call came in a different way, do you mean that 911 contacted your team, or is 911 dispatching your teams?
So it would be coming into the police station, basically, through their 911 line, and the call is determined to be a one or a two, and they've determined that that clinician can dispatch by themselves with the peer or parent partner. And just the dispatch tool wasn't used, because the dispatch tool is only used through our 24/7 crisis line, so to speak.
So the dispatch tool does have to be used by any team. So any team that's taking the call that could potentially dispatch the mobile crisis team under the benefit would need to utilize the standardized dispatch tool.
Okay, so if the call comes to them, then if the clinician uses the dispatch tool to just run through it, then it could be billable, even if the call came in through a different way. If the clinician completes it, would that be okay?
Whoever is taking the call, and if that person, whether it be through that regional call center, if they're taking the call and they're essentially triaging the call to determine if it is a call that meets the requirements for a mobile crisis benefit team, then that person needs to be utilizing the standardized dispatch tool, either the DHCS one or the one that your county has created and has been approved by the state. Does that answer your question? Thank you, Vanessa. Okay, I believe Vanessa has one more question. We are getting some questions from our billing department about adding more than one provider to each claim for the mobile crisis benefit to include the mobile crisis response and follow-up services. Do you know if other counties are tying the whole claim to one provider and just documenting with 2 to 3 providers? Or is it a requirement that the claim is tied to possibly 3 providers to include the follow-up at the state level?
There's one claim per team, and there only needs to be one documentation per encounter or interaction. It doesn't, you don't need to have multiple people doing documentation on the same event. So you're doing an event about the mobile team interacting with the person. And if DHCS wants to add anything more to that, please do.
This is Chuck again from DHCS. I'm not sure that I fully understand the question.
We
Is
can-
this also from Vanessa?
Yeah, Vanessa, would you mind coming back on? Thank you.
Yeah, no problem. So with the benefit, two providers could provide the service, and then possibly even a third provider that didn't respond in the initial response could provide the follow-up, which also has to be documented. So we were just asking in our system if the follow-up would have to go up, you know, tied to that person's MPI, tied to that provider, or if it could just go up under the provider that provided the initial response.
Okay. Is it primarily a documentation question, or are you also asking when you submit the claim for the mobile crisis service, what rendering provider NPI goes on the claim? Is that also part of your question?
Yes.
Or is it just what do you record in your EHR?
Exactly.
Documentation?
Yes.
Okay. Thanks.
Thank you.
I don't have a response or anything to add to what was said earlier, but I think we can take it back and have some more conversation about it.
Thank you, Chuck, and thank you, Suzanne and Vanessa. All right, we will make sure to capture that question so we can get you a response. Moving on, this is from Jill. Lockout settings / restricted settings. We are getting questions whether this is specific to SUD residential / ED facilities / etc. that are county Medi-Cal funded only, or including private pay, private insurance facilities. And I think that might be a DHCS question.
It's the facility type, not how they are paid. It's the kind of place. And this is all coming from federal, it's being driven by federal regulations. They're trying to make sure that this is going to people in the community and responding to people in the community, and not using mobile crisis to respond to people in facilities. And so it's less about how that facility is paid, but more about them being a facility and it not being a community-based, going to the community to respond to someone.
Yes, that's correct. I have one other thing to add. This also is in our BIN 23025. So it does mention the service settings that are restricted, and there is a note that these are restricted due to federal law, and then there's a reference there, but also they may be restricted if the settings are already required to provide crisis services. And so that would be something to consider as well when determining if a specific setting is restricted or not.
Thank you, Corinne. I believe Daphne's question is related to Vanessa's questions in regard to the encounter being billed utilizing the team's MPI number rather than a practitioner's number. And then there's also some follow-up from Jill around what San Diego County is doing. So I think we'll take all that and we'll work with our partners at DHCS to get some responses to that. The next question I see is, how should the follow-up be documented? A significant non-billable note. I'm not sure if there's a typo there. This is from Michelle.
Hi, yeah, this is Michelle. I just wanted to know in the follow-up note, if you have to provide evidence that you provided one, and or if you didn't provide one, but it's not a billable service by itself. So is that a freestanding note that's supposed to be in the EHR that's considered a non-billable note? Or is it supposed to be an addendum to the original batch service note?
Yeah, I can provide some information on that. So there is a section also in our bin on follow-up check-ins that provides some details on what is expected, the timeframes, and then there's also documentation. And so the documentation is required to meet the documentation bin. A new one was just released. I believe it's 23068. Don't quote me on that. We can put it in the chat when I find it. But it does indicate that it would be part of the progress note, I believe. And you are correct that it would not be a separate billable service, as it is required as part of the encounter.
Thank you, Corinne. And it is 23-068. I just put the link in the chat for you all.
So then the note would be a freestanding note or an addendum?
I would need to review the documentation bin to see if there's a specific requirement. If it's not stated in there, then I don't believe that there would be a
Okay, thank you.
specific guidance. You're welcome.
Thank you, Michelle. Thank you, Corinne. Next question is from Lori. On the claim, would the mileage A0140 be the round trip mileage for the team, not per provider? And would the transport staff time T2007 also be the time for the team and not the sum total for each person on the team? For example, the encounter was 5 miles away and was from 1 to 2. Would the A0140 be 10 and the T2007 be 4 units? Example, 15-minute increments.
So this is Chuck from DHCS. So the mileage would be the round trip mileage for the car, for the automobile, and not the people inside the automobile. So it's not multiplied by 2. The T code, and I'll apologize, I don't remember all of these off the top of my head, but for the staff time, then each staff would bill separately, and they would bill their time, how much time they spent going from and to. So one is mileage, the other is time. And if that wasn't clear, please let me know. You could try it again. The procedure code wouldn't be H2011. The procedure code would, for the time that they spend transporting the member to another level of care and potentially sitting with them and waiting for them to be admitted, that warm handoff is not billed with H2011. It's billed with the T2007. And again, I may have gotten that code wrong. And each member of the team that participate in that warm handoff would have a separate service line on the claim with the T2007 procedure code and the number of units associated with the amount of time that they spent performing that warm handoffs. So in essence, it's like the service is a warm handoff. Both are providing the warm handoff at the same time. Both can bill for the warm handoff at the same time. And each is billing the amount of time that they spent doing that warm handoff.
Okay. And that would be a separate line or separate claim from the H2011.
The H200 or 011 is with place of service code 15 is what will generate the encounter rate.
Mm-hmm.
And then on top of that, as I think was explained earlier, the sort of warm handoff function is separate, both the mileage for the automobile and then the time of one or more team members who participate in that warm handoff is separate.
On a separate claim?
It can be the same claim, but it's a separate service line. So within an
Okay.
837, right, you have a claim. Within a claim, you can have multiple service lines. And so one service line could be H2011, one unit, whatever the encounter rate is what you get paid. And then you can have the A code for the mileage on another service line.
I see.
And then
Okay.
the T2007 for the warm handoff on one or more other service lines within the same claim.
We have a question from Shirley. Please clarify if requests for this benefit should be coming in through the county's 24/7 crisis hotline or access line or 988 versus if the calls can come in via 911.
I can answer that. So there's a section also in our BIN, the dispatch of the mobile crisis teams and the crisis services hotline, which address this. And so there is supposed to be a single telephone number. And so that is identified in the implementation plan that was submitted. So each county should have a single telephone number that will be utilized for the crisis services hotline. Now 911 and 988 are more than welcome to like refer or send calls to that line as well if they think that mobile crisis may be beneficial for those callers. But there should be one phone number identified in the implementation plan that serves as the line that any Medi-Cal member can call who requires mobile crisis services.
Next question is from Carrie regarding follow-up and documentation. Under doc reform, there is a requirement that crisis documentation be completed within 24 hours. The follow-up documentation will not happen until the follow-up occurs. I think the confusion is coming regarding how and where to document the follow-up when we have already finished the crisis encounter note. Clarification on how DHCS would like us to handle that would be beneficial.
That's a great question. We have a reform team, so I think that would be a good question for us to take back to them and make sure that we're all aligned on what that message would look like. Thank you.
Thank you, Karine. And next question from Lauren. Are these documents provided by DHCS dispatch screening tool and the encounter follow-up note that includes fields for the required elements? The dispatch screening tool, there is a standardized dispatch tool that was created by the state. It is available on the MTAC website, and we will drop that link in the chat. All of the standardized tools that were created by the Department of Healthcare Services are available on the MTAC website, and that is the dispatch tool, the crisis assessment tool, as well as the safety planning tool. Counties are able to use those tools as their standardized tools. You are also able to create and develop your own. They just must be approved by DHCS prior to using those tools for the benefit. In terms of the encounter follow-up note that includes fields for the required elements, at this time there are no standardized tool for that or an example. Karine, I don't know if you want to add to that.
No, I think that can just be a free text like note, as long as, again, it follows sort of the requirements that are outlined in the BIN under the follow-up section. But I don't think that there will be any sort of tool created for that.
Thank you, Karine. And I'm going to go to a question in our Q&A. In our community, we have encountered numerous situations where we receive requests from law enforcement to locked facilities, for example, county jails, federal detention facilities, and similar locations. Due to a subject who is being admitted or submitted for in-custody status as they are arrested, but they're being rejected by the facilities due to the subject reporting suicidal ideation at the time of admission. Since the subject is not admitted, would responding to said requests be billable under the benefit?
I'll respond to that, and then DHCS if you have additional thoughts. So the federal requirements say that those kinds of facilities can not be reimbursed under this benefit. However, for counties that have found other resources, you could bill for that under other kinds of, from other funding sources, but it's the federal regulations that are driving the facility type, and you cannot reimburse for mobile crisis under this benefit.
It looks like we have one question. The follow-up will be difficult to connect to the original engagement for clients that have multiple mobile crisis responses in a short period of time, which is why documentation clarification is needed. Okay, thank you, Michelle. We will, I believe, the DHCS team is going to take that along with the additional question around documentation and get back with that. So we will take those questions and comments and make sure we provide a response. All right, now is the time to ask any questions you might have around billing and reimbursement. Please, again, feel free to unmute yourself or place your question in the chat or in the Q&A. I don't see anything new so far, so we'll give it a minute for anyone who has any last minute questions. I also want to give DHCS the opportunity to take the mic as well if there's anything you'd like to share or add. Appreciate you all being here today and providing the clarity that you have provided. It's been very helpful. And Suzanne, thank you as well.
Yes, hi, my name's Curtis with Placer County. For some reason, I'm logged in under Leslie, who is my colleague on our children's side. So I apologize, but this is Curtis Budge with Placer County. Maybe just a quick, and this could be maybe in a TA session as well, but you know, the dispatch screening tool, and we are going to use that. We have not developed our own, and it seems like a good thorough tool, but it seems unreasonable to use that when a police dispatch is calling. I guess I'm just, you know, in practice, when a 911 dispatcher is calling to refer someone for mobile crisis out in the community, they want to be on the line for 30 seconds. They don't have 10 minutes to do this dispatch screening tool. So maybe I'm missing something. I'm just wondering if someone could chime in on how practically that's supposed to be used when a dispatcher is calling for a referral with officers standing by on scene with the client.
I appreciate your question. Just to make sure I'm understanding correctly. So you're saying when law enforcement calls in and requests the service because they're with someone, they responded to a call and they've determined, you know what, this is more of a mental health call. This person would benefit from a mobile crisis team.
Yes, and all the other requirements of the BIN would be met. The law enforcement is not part of the team that's responding, but they are referring and they're on site and they would like us to respond quickly. And the dispatch personnel do not want to stay on the line for several minutes answering the various bits of information from the dispatch screening tool. They just want a response. We generally take their word for it and we respond quickly so that they don't get upset and we can be there quickly. So they'll keep referring. So those are kind of my questions.
Danielle, I don't remember it as far as the name Leslie, but I know it's not Leslie. But
Curtis.
Curtis, yes. So why don't we take your comments back? There is a requirement to document, but let's take your comment and talk about how to meet the requirements of completing the tool, but to consider like the practical applications of like the scenario that you just brought up. So let us take that back and clarify some more, thinking through some practical applications.
Yeah, that would be great. And just also obviously keeping in mind that, you know, we have good relationships with law enforcement in our county, but often they're difficult relationships. And so this is not going to help to have to be so thorough in that initial information gathering. So yes, thank you very much.
Yeah. I've heard many police say, don't ask me a lot of questions. You told me to call you for help when you have someone that needs help. I'm doing that. So let's circle back and think particularly that scenario that you bring forward and provide some more clarification.
Yeah, thank you, Suzanne. And there are so many scenarios that can come forth when law enforcement is calling out, right, and asking for a mobile crisis benefit. They may just be doing a warm handoff and not necessarily staying on site, because there may not be a need for them to stay on site. And so they may actually put the person in crisis, or a family member or another collateral who's there who could provide the information in that moment. Or like Suzanne said, it's something that we can take as a scenario and try to find practical ways to make sure that the dispatch tool is utilized and completed for the encounter, but maybe not directly in that moment, when it's more urgent. But we will definitely take that back. Christina, I see you have your hand up.
I put it in the chat, thank you. I was just gonna ask if that answer could be shared with the group, because we have similar thoughts as well with Curtis.
Absolutely.
Yeah. And Christine, if you have other scenarios, like like what's the practical scenarios to help think through some things that would be helpful. And I just want to follow up with, law enforcement asking, generally law enforcement, they're pretty good at knowing this is emergent, we need EMS, not a mobile team. And they get folks to those kinds of services quickly when they see those things. But there could be, it's not a matter of filling the form out, right? It's a matter of getting the right information and making sure that things are dispatched. Like that's the essence, but then you have to document things. So, just because a particular system partner asks us, there could be a couple other quick questions to ask to make sure that it is the right, like understanding, if it's someone with substance abuse, and making sure that that there's questions asked to understand, is this a medical emergency, to make sure that if that's also needed, that a medical emergency response is also responded to. So we have to make sure that people ask the right questions to make sure we get the right response, and people are that it's safe as well as the right response. So, but we will take those scenarios and talk more about how to make that logistically possible, while also, fulfilling the requirement of completing the form. And sometimes it might be right after you've dispatched, because the questions in your head, and you're answering. They've already provided that information, and it's a matter of documentation. So we'll think through all those kinds of scenarios and provide an answer that's helpful for you to be responsive, yet also being compliant with what's required. So,
yeah, I do. Thank you so much, Suzanne. I do see Ruby, you have your hand up, and then there's also a question from James in the chat. So I'll hand it off to Ruby.
I'll be very, very brief. I just wanted to make sure that I provided a little bit more context as we work with law enforcement. We do provide them presentations. They understand, when it's appropriate to call a crisis team. And so in those situations, we want to be, good faith partners, and really take them for, I have not been to a scenario where it hasn't necessarily been an appropriate situation when police is requesting us. So they're really good about, taking what we provide to them as training and information. And that's where, yes, doing the dispatch tool might be a disservice to the person that is needing the support. And also it goes a little bit against, freeing our law enforcement to do their job out in the community, if it means that we can handle that specific call. So just wanted to provide that as a comment and to be taken into consideration.
Thank you, Ruby. Appreciate your insight and just, your comment. Thank you so much. The question we have from sorry, scrolling back up. I believe James, is the requirement from ARPA or the state? I'm sorry, James, which requirement are you referencing? Are you referencing the standardized tools, or?
Referencing that the standardized dispatch tool has to be used the way that we've dictated, versus if a call comes in through dispatch, as the other questioner asked. So is that requirement around the standardized dispatch tool from the feds, or is it something that we've developed at the state level? i.e. is there other wiggle room for, hey, this call comes into 911, this 911 dispatcher sees that, hey, there needs to be some safety precautions taken care of, but we also need the mobile crisis team there as well. So the police are going to show up first, we're fall behind, but we don't have the dispatch tool being answered.
Thank you, James. Again, we'll get back to you all in regard to the potential flexibility or what that might look like when law enforcement is calling or requesting our 911. The standardized tool is a state requirement, and that is, you know, across the board for the dispatch, the crisis assessment, and the safety planning tools, to be utilized under this benefit for each encounter, when appropriate for the safety planning tool, especially. I don't know, Corinne, if there's anything you want to add to that.
Sure. Yeah, I think these are great scenarios and definitely something that, you know, it's hard for us to consider every scenario. We did try to get some feedback on multiple rounds from the counties on these tools, but we are always open to additional feedback, and there is always the possibility that they could be updated. And so I think this is something that we will take back and discuss. There may be something that we can update in regards to, you know, is this a direct, you know, essential like referral or something from an on-site law enforcement, or, you know, something like that, that we may be able to add to sort of make the tool a little bit more user-friendly for these scenarios. So it is a requirement, but again, we are more than open to feedback and certain scenarios from the county. So this is great. And we will definitely take it back and discuss it and make sure that everybody's aware if there are any changes made.
Thank you, Corinne. And thank you all for your questions around the tools. Really, really appreciate it. I'm just double checking in the chat if there's anything.
Yeah, I did have a question about modifiers. I think I'm a little confused with the is it the telehealth, the GT modifier? So the GT modifier is associated with transportation, staff time, and the actual encounter, but it says to use this just when it's telehealth. So could we maybe expand on that? Because does that mean it's only attached to the provider who's being called, who's remote, who is but not the two providers who are actually going out to the scene? And then how does that would be a separate encounter where they put the GT, but they wouldn't be putting it on the mobile crisis encounter or the transportation or mileage, or I'm confused about that.
This is Chuck from the HCS. I think that's one that I'll need to take back and think about. Did somebody document that question, or can we get it documented so that we're responding to it accurately? But I
Yes,
don't
we will
know.
provide to the DHCS team a list of all the questions that require follow-up. So we're documenting all of those.
Thank you.
And we will disseminate to everybody who participated today, and make sure that anything that follow-up information is shared widely.
Thank you, Chuck, and thank you, Lori, for your question. All right, giving one last chance for any additional questions. I'm not seeing any hand emojis or anything new in the chat or in the Q&A. I don't know, DHCS team, if there's anything you'd like to add before we close. I want to give you the opportunity to do that if you'd like to. If not, we can close up.
I just want to say thanks to everybody. I know that this has been a lot of work, and it was really, we were really glad to see that all of the counties implementing this year in December submitted their implementation plans on time, and to see all the work that has been happening. I know this has been a long process, and that a lot has been happening, and you guys are working really hard to make this happen. So we appreciate the questions. We are working hard to provide answers and work through all of these things with you. So please keep them coming. We appreciate your engagement. And so just want to thank you guys. We realize that this is very big lift, and the time frame is very quick. And so we really appreciate all the work that you guys are doing, and we know that these services are much needed. And so just want to say thank you to everybody.
Thank you, Corrine. Again, thank you to the DHCS team for being here today to answer questions and provide clarity. Suzanne had to log off, but thank you to Suzanne as well. And for all of you just being here and sticking past the time and answering your very important, great questions. We will do our best to get you responses as quickly as possible. Again, if you have any additional questions, feel free, and we'll drop all of this in the chat to email us at the MTech team. Email will be dropped into the chat. You can also request TA from us on the MTech website, and we can support you, with your implementation plan or any support you need in regard to implementing this benefit. And thank you so much for joining us today, and I wish you all a great rest of your Thursday.